everything is fine. So I go back to my ultrasound from the MOH that the spiders actually not there. So now to show that we have a lady with visible spiders and also this corner. Here she has visible spiders. If you look at here, she has the middle of the beginning discoloration, brownish. It is not so light on, but it's all liners or anyone. And so here is a little bit of discoloration, and if I press, there is a little bit of edema. It is fine. So she is symptomatic. She is C2, she was compression, and we will treat the next weeks. And today she has offered us to see her like before treatment. Yes? I start with the line as we have always done. Perhaps, Magnum, do you want to show? I have another. I have my setting. My setting in the room is I have this where I treat the patients when I look, for example, in the related therapy. There I have a second screen on the wall. So when I treat the patients, I don't have to go down and pull down with my head, but I can look straight forward. For doing Sclerotherapy, I can put all on the lights and see better the veins with ultrasound without the light or directly with the light. This is my personal setting. Don't destroy my eyes. You have to be careful the latest change. Yes. So we have the artery, the deep vein in the groin.
Yeah.
Junction of
Pressable, the junction, we can see it, yeah.
In the second element, the very interesting thing, we have a pudendal vein draining directly to the deep vein. I always say if we can put the hand like fingerprints, I put to identify every person by this unbearable meanings. So we have the compression, and now we look at the junction in non-material also. Oops, that. Sometimes it's so easy when the bleeding starts as still. Doctors never get happy. They say you have to not be obese, and for ultrasound, they say you are diseased. So this is the junction place. But the vein is so thin that I can't even make a watch.
I cannot see the junction yet, Erika.
Oh, no, just which.
Yeah, all right, we are waiting.
That is the junction, but there is no. Perhaps you can do the other side on now.
Okay.
So what I'm doing, I actually look for iPad and keeping it all right.
There is no flow in the Cameron. Yeah.
Right up. There was a little tiny flow in the epigastric.
The reflux, yeah. From where it comes? From the epigastric or from where it comes?
It was like here, but it's a healthy flow. Was an only problem that it's notice if I can tell you there is no refluxing. Definitely there are people with another prostatectomy. There is no sucking vein. There is no sucking vein here. She was already she had surgery, and there is no sucking vein. It's right. And nobody told me there is no sucking vein here. You have a little bit of a stump here.
This yes. Yeah.
Yeah,
and there was a tiny reflux from where it comes from, the epigastric vein.
I don't know, I'm a teaching floor.
Yes, this one, yes.
I think it's quite up and correct. There's a little bit of epigastric vein.
Yeah.
Okay, so we look in the esophageal channel.
What type of modality has been treated with surgery?
Surgery, prostatectomy and surgery. So we see no reflux. Here we are. I go to another place here to spinal concept. If you go to the inner thigh, here is the subcutaneous eye. But there is no vein inside. Yes. So there is
no eye.
Instead,
but we have a superficial vein, superficial access.
Just ignore it for a
Just
second.
under the skin, we can see the vein, yeah.
No, but I know where we might just want to check if we want to use vein was really stripping works. So now we go down the path where the vein was stripped and we find the vein here. And we have to have a look where it comes from. And here it helps us. This one is circulating vein after stripping.
Yeah.
Yes, and as the question we had earlier, this is the place
The thigh perforator.
like to investigate it properly. Yes, very trespasses the muscle question. Don't really see any. Even gonna see.
Wow.
Obviously, reflux,
A big reflux, yeah.
perforating vein. Yes. So, and it trespasses the fascia.
Exactly.
It goes from the muscle fascia into the fascial compartment of the sapina, and then it goes out the sapinous compartment. There is an epifascial cavity, and I can demonstrate to you what all the patient has on the calf. This is the tipping maneuver. I like it. Yes, you show. If I sit here, or I tip where there is no vein here, the calf. But if I tip on the vein, it is obvious that the vein I'm tipping is filled by the other one. And we can do another test. In the right zone. On what else? This is the flow movement maneuver.
Yeah.
If I press on the vein, there is an automatic cessation of the reflux upstairs. Now I release and it flows. See, I press it below the knee. I'm not seeing it.
Then it's low.
I slow reflux. So we know that all what we see here is
From the
separating vein.
perforator, yeah. Yes. So it's an important source of recurrence, huh?
Yes. So these perforating veins on the side are frequently will be observed in cases of previous stripping or lasering or closing of the saphenous tract. There is a good work from Spain that they demonstrated that 6% of recurrences after stripping are perforating veins, filling the new visible veins.
So interesting, very interesting.
So here we see the following. Here's a scar. And she has been stripped only until this level of production of Is there a scar where she has been stripped until the outcome? Yes. But here we see that the vein, again, tributary goes inside the fascia and out again. It makes like a little keeper. Yes. And then you have all these veins. Like, which would be the treatment for this patient? What are the proposals from the floor? What would you do, Basila?
Yes, maybe.
What would you
We
do?
will ask, maybe you repeat the question, please.
Which would be the treatment for the vein? What shall we offer as a treatment? Compression, of course.
Compression, of course.
I mean, normally you should put compression on veins when they're born. Yes.
She has symptoms, Erika. She is complaining from any...
She has swelling, and she doesn't like me. She's a wonderful young lady. But it has a bunch of happens less. And she has edema. She has
How long is the column of the superficial vein? The length of the superficial vein, how long?
from here.
Yep.
Yes, here. This is 60 centimeters.
40 centimeter. You have the measure, you have the masura.
You have a meter. A meter, yes. Okay.
So we got an answer. Interrupt of the perforating vein from Saza
Yes.
Lizai Villagesic. I am quite sure that I pronounce the name very, very bad. Sasa, from Dr. Sasa.
Yes.
So interrupt the perforating vein. This perforating vein interrupted. The thigh perforating vein.
But if you want to do this properly, you have to go 3 centimeters below the skin, 2 centimeters below the fascia, and you have to interrupt it really, really like this level, because otherwise you will leave a stump. Now you can't see that it's for one. Yes, you can.
It's so big, huh?
Yes, and you have a stump. So my option will be I will approach the tributary, wait, at this level, just before it enters the fascia. Yes, here I will go inside it with a needle, and I will inject foam. I do a very dry foam, which is for these occasions. This is 1 part of 3% ethoxysterol, and only and 7 parts air, not 1 to 4, but 1 to 7. This is the dry foam, and you make a very hard foam. You can really see how it moves, and you can stop it. You can stop injection when the foam reaches this line, just before this junction. With
Erika, we have some points about the deep system from Peter Samak, that this lady have a deep vein reflux. And from Erwin, is everybody seeing scar tissue in the deep venous system? Could you scan the deep system, please, Erika? The femoral vein at this level, if there is any reflux, or even by B mode, if you can see any synechia or synechia from previous DVT. This is competent. This is healthy femoral vein.
The defects are really perfect. This is just a recordings from the laundry perforating veins in the stricken process. Did you see there was?
I cannot see scars, but we can thoroughly elaborate with this with the B mode.
Yes, the deep veins.
This is the answer for the hemodynamic. So there is no deep vein reflux. What about the remnants of the old phlebitic changes? We cannot see it, huh?
Oh, no post-phlebitic changes. I don't need the answer. I will work with for medial vein. This is the classical perforating vein reflux due to superficial venous competence. The deep vein is perfect. I know what's in on the contours are perfect.
You are on the popliteal vein now. Where you are, Erika?
The vein, yes. It is a perfect venous system.
It's competent. It's healthy vein, yeah.
Perfect, yes. So I will do a Sclerotherapy because in my experience, it is the less harming. You don't have to open the fascia to go to the venous system to make a surgery. And this is the less harming option. And in the same session, I can close the perforator, solve everything until the calf, and the lady will have a cosmetic result with 1 session of Sclerotherapy. She will wear stockings, of course, 2 weeks afterward.
I would like to thank you. The patient was very patient. She was very kind. Thank you. Thank you so much.
Just one thing, when I make the compression after Sclerotherapy, I put not a towel, but like this things you use for operation person on reason in English. I put things. I show you where I think that up. I don't put in English today.
Mahmoud, we can change now the screen of the ultrasound, because the screen of the ultrasound is the major screen now. Could you change this?
You see, there's one. I would put like this, was normalerweise sieht. After Sclerotherapy, I would make like this on this plates and put it inside. You see.
But we still see the screen of the ultrasound machine, Erika.
I know. In the screen of the ultrasound machine, you see me. Hello?
But we can see, now we can see with Erika Mendoza's screen, yes, we can see.
I stop, okay, I get the point. I stop this.
Yep, and now yes.
So I would put these things over the leg.
Yeah.
But you have to take clear the MOH background because I can't see.
Can you move the MOH background and Dr. Erika Mendoza, please?
Okay.
Good.
Okay, you perhaps see there that I have like extra compression here. I will put this inside the stocking so to allow a better compression, a decentral compression on the perforating vein after that sclerotherapy. Yes? Okay. Nobody is happy.
With the camera here is taking the voice. That's why it's
Okay. Do you see the camera from Mahmoud? You see perfectly. I have put extra compression here after the sclerotherapy to allow a better closure of the perforating vein. So I think, yeah.
Khalid, can you please remove the background of Dr. Erika Mendoza?
No, that one. I will release the patient and tell you next time how it worked. Not going to have not want me to. I can walk out and way what else should get. Okay, so I think we have done the presentations. Are there still questions open?
I would say that we have almost done all the questions, but we have still some. I mentioned Attila Puskus, we close the perforator, but we have Claudine Hamel-Destus with us. For sure, it is a good indication for foam sclerotherapy. I would inject 1% polyducanol foam in the varicose vein at the thigh level. Thank you, Claudine, for your valuable contribution. It's a true honor having you, Claudine, with us.
Yes.
This is for the line of treatment. One, I asked you, what about how to treat this superficial tributary? And another question about what is the ratio of liquid and air you mentioned for the dry foam.
Okay. The issue, if you have less, I mean, I will come back to Claudine. Of course, the tributary, I will also treat with 1%. I would just use like 1 milliliter of this dry foam, 3% for the interfascial segment. And why is this dry foam? Massimo Capelli showed it to me. This is 1 milliliter of 3%. You have to use a high percent sclerotherapy agent. 1 milliliter to +7 of air. So you have 8 mils at all. And it is a very hard and dry foam. And if you do it, I again invite you, the 21st of September, I will do that and show it. It is like you can make a drop and it's like a globe, but it's so hard that you can really slowly see it moving inside the vein. And I would only apply 1 ml. Then I will take 1% for the rest of the saphenous of the tributary.
There is a lot of tips and tricks for the foam sclerotherapy. And really, there is a lot of details, and really the devil is in the details.
Yes.
Yes. So when you go very slowly, you make the vein on spasm, so you deliver very slowly, gradually.
And ultrasound,
of course.
Yes.
No foam without ultrasound, of course.
No. No.
And saying this, Claudine herself has very interesting publication about the comparison between 1% and 3%, and there is no significant difference. So 1%, I do agree, as you mentioned, Erika, 1% is quite enough for...
Yes, but with 1%, you can't do this dry foam. And I mean, there was a real high-speed reflux in this tributary. So perhaps if you use 1%, you have to treat it twice. Would also be an option. And what also is a trick, I would always, after 3 weeks, have a look once for the discolorations of the vein and the incision and expression of the sclerothrombi, but also to make sure I've closed the vein. I always explain to the patients that when I treat these perforating veins, these large veins with high pressure, there is a 20% chance to having to redo the sclerotherapy after 3 weeks because it is not completely closed.
And we cannot close this without asking about the compression for the duration, because we do compression after full sclerotherapy. But what type? Is it eccentric compression or short stretch bandage or compression stocking? And the big question always in every webinar, in every conference, for the duration. What we would say, Erika, from the compression?
I really always use class 2 compression, covering the highest point of the sclerotherapy. So if I do, for example, a recurrent after prostatectomy in the groin, I always want a panty, because the point I form has to be covered. If it is a little varicose vein, I use class 1. But if a patient shows up without compression, I do not treat him, because I'm completely convinced, and there are studies published on it, that the result is better if you compress. Earlier in Germany, this bandaging was used, and with little like compressions, extraluminal compressions of the places. I don't do this, because the bandages get lost as soon as the patient has left the office, and the stockings remain in situ. And always I ask the patients to remain with the stockings the first night until there's in the second evening. So if I treat them today, until tomorrow in the evening, they have to stay with their stockings, and then they can put them off and put them on in the morning. And this is much more comfortable to the patient than having bandagings. So this is how I do it. I think this is very empirical, but there is one publication demonstrating that 2 weeks compression increases the results of the sclerotherapy.
Thank you, Erika.
Thank you, Vasila. You were making wonderful questions, and sorry that I didn't answer them immediately, because I was just thinking, I'm an old woman. I had to finish the first topic and then come to the next one. But you was wonderful guiding the interventions, so the investigation. Thank you so much. It was a pleasure as always.
Yeah, I think it was really, really great. Thanks so much, Dr. Erika Mendoza, and thanks so much to Vasila Taha, and also thanks so much for the great input and the comments, questions coming from the audience. I think we planned to have 90 minutes, but ended up with 120 minutes, 2 hours of really interesting. I didn't feel the time. Really, really much appreciate all the knowledge and experience that you shared with all the audience. I have received already so many messages in different channels. We were also live on social media. We had hundreds of attendees giving really a good comments so far. So thank you very much to everyone, especially, as I said, our expert speakers, panels, moderators, and also for the great comments from the audience. Before we close the MOH Connect, I just wanted to mention again that I just shared on the chat the link of our Medical Online Hub platform, where you will find different materials along with the recording of this event will be very soon available there. Then you can also refer to that. Also, we have uploaded some studies and the researches relevant to the same topic. You will find it also under the MOH focus section or MOH bulletin. So you can check it more for more information, also to follow the upcoming events. Dr. Mendoza mentioned in September, it's 14th of September, not 21. Today is 21. Make sure that people are actually booking their calendar. So thanks so much, and hopefully to meet again soon in the upcoming event. Please feel free to reach out for any information needed after the event. Thanks so much.
Thank you so much. Thank you so much. Thank you, Erika.